super good morning to everyone listening in. Well, at least it's morning in Johannesburg, South Africa, Kampala, Uganda, Nairobi, Kenya, and you joined in by different colleagues today. My fellow colleague, Wako from NCDChild, Young Leaders, and Dr. Kanyike. I am Shakira, Choonara, and really glad to be co-hosting this session with my colleague, Joab. We have an entire series, a really exciting series where we're delving deeper into patients living with NCDs. Now, NCDs or non-communicable diseases, such a big term. How do we just break it down? It literally means living with a chronic condition, a long condition. The most common ones tend to be heart disease, lung disease, for example, diabetes is well known, and then you have rare diseases as well. In this podcast series, we're titling it Stand Up and Speak Out. And the reason we're titling this is we're focusing on stigma and discrimination. Now, we know that stigma, for example, in working in the HIV field for a long time, this is where we're really borrowing on for the series, is stigma refers to the negative attitudes and perceptions that one has. And discrimination is when one actually acts out on these negative attitudes, etc. This has been less explored in the NCD space. And the way our campaign is structured, at the heart of it is that World Health Organization document and consultation, which said, how do we meaningfully engage people living with NCDs, etc. And in early 2021, Joab, myself, Alex, Apuva, Belindi, we all are young leaders. We came together and we put together a survey and we asked patients worldwide, what do you want to do? How do you want to raise awareness on stigma and discrimination? And so it's a series of 5 to 7 episodes where we speak to patients, but today we really have the great pleasure of interviewing a healthcare professional. But before I go any further, I want to hand over briefly to my colleague Joab and fellow young leader and activist to introduce himself as a fellow co-host this morning.
All right, thank you so much, Shakira. Like Shakira said, my name is Joab Wako, and I am based in Nairobi, Kenya. I am a person living with an NCD, and more specifically, living with chronic kidney disease. I've lived with chronic kidney disease for the last 8 years, and I got a kidney transplant 7 years ago, and that's what sparked off my advocacy. It's really nice to be here, and thank you so much, Shakira.
Oh, I was just gonna say, Joab, the first time we had met was in Dubai, right? Sharjah.
Yes. And it was such a good platform, and I was amazed by the number of young advocates there who are doing amazing work like yourself.
And I think to, those listening in as well, Joab is just so interesting, even being a co-host, because he's been an activist for so many years within the NCD space. And we'll turn to Joab in a little bit as well. But to mention, Joab, that I followed you avidly on social media. I got the opportunity to meet you in Dubai. And I've heard your story about dealing with your kidney issues, but also how you're not just an activist, you're a survivor. And you're here with us today as well as a fellow co-host. So, Andrew, without further ado, we should get started and get into having your really interesting perspective. Could you let us know, let the listeners know, tell us a little bit about yourself, where you're based, what sort of work you do. I know that you're a medical professional, but please do feel free to delve deeper.
Okay. Thank you so much, Shakila. Thank you for having me on this podcast, NCDChild. And it's really a pleasure to be here and share a platform with you all. It is a great pleasure to share a platform with you, Joab, and get to know about your story. It's really interesting. I am Dr. Kanyike Andrew Marvin. I'm a general medical doctor at a private non-for-profit Christian-based hospital in Uganda called Mengo Hospital, with an inclined passion to NCDs, especially diabetes mellitus and hypertension, because they are the most prevalent in my environment and I've picked interest in them. I'm also an early career researcher. I've published work in this line of NCDs, but also have a lot of ongoing projects on non-communicable diseases down here in Uganda. I'm also a co-founder and a general secretary of an organization, a non-profit organization called Health Touch Uganda, where we major deal with spreading awareness about non-communicable diseases, doing community projects like active screening and detection of hypertension and diabetes mellitus in our community. We do a lot of social media awareness campaign, Twitter spaces, we do Instagram, we have a website, we engage the community to tell their stories. Like this month, we are doing basically about cancer, and we have got a lot of interesting stories from different people about what they have been going through. So we are basically taking up the mantle to blow the NCD trumpet in our community, which I believe whose silence is very loud as regards to the number of patients that we really see coming in with undiagnosed NCD complications in the hospital. Briefly, that's what I do. Thank you so much. Back to you, Shakira.
Amazing work, Andrew. It's so important as a healthcare professional to see that you're in advocacy as well, and that the patients you meet have impacted you so dearly, that they've made you do something about it. That's something that's not very common. So as a healthcare professional, could you please tell us more about your work? I know you've mentioned that the different NCDs that you've dealt with or seen, and diabetes and cancer being some of them, but maybe you could delve deeper and just let us know the bigger projects that you've worked on, what you're super passionate about, and the impact you've seen so far.
Thank you so much. So down here, I should say that we are experiencing a transition, a trend, changing from seeing a lot of the infectious diseases that we have been seeing in the hospital to the non-communicable diseases. On my ward, I can literally have 3/4 of the patients battling non-communicable diseases, hypertension, stroke, chronic kidney disease. And what's astonishing is that at first we thought that these were majorly diseases of the elderly, the grown people, but we are having a lot of young people. And just right now, I left ward to come and be part of this podcast, but I have a 23-year-old who is battling with kidney failure, end-stage renal disease. And you all wonder, and you're like, why is such a young person, facing such a catastrophe that you wouldn't be expecting? So it is really a big problem that I think has really not been given much due attention as yet, because we are still battling with a lot of, the infectious disease burden. But I believe like we may wake up on the side of, an outblown double disease burden that we may not be able to handle if at all we keep keeping a blind eye to these diseases. So as a health worker that is passionate about this picture that I'm seeing in the hospital, that's why I've taken up, that step together to join with other passionate people to come up with, this non-profit organization that I've told you about. And we have decided that, we are not going to only, talk on social media. We are not only going to talk to the patients that we are only seeing in the hospital, but we are going to go down in the community and let these people know about, these diseases. So we go into the community, we screen people. Actually, I've just received a grant from Aspire Institute, which is based at Harvard University, to carry out a project on active case finding of hypertension down in a community in Jinja, near the source of the Nile. I know Shakira said would want to go to the source of the Nile. So Jinja is one of, the peri-urban area or urban areas because of the tourism. And, a lot of people change lifestyle when that urbanization comes in. And it's an area where we are seeing NCDs cropping up so much. So that's why we are going down in these communities to capture those people that are moving with blood pressures that are through the roof, but actually they don't know because most times it doesn't come with symptoms. But if we do nothing, they are going to come to us in the hospital when they have kidney disease, when they have hypertensive heart disease. And that's what we don't want. And also we are seeing a lot of cervical cancer. And this is another non-communicable disease that is really a very high burden. So we have also taken some caution to go to schools, to these adolescents, because all these risk factors for the diseases are embedded within the adolescent stage. And if nothing is done about them, they continue growing up or grow up with them. And so we want to create the awareness as deep down from the grassroots as the teenagers and the adolescents. And actually one of the other project that I'm working on is about profiling non-communicable disease risk factors among adolescents in school. We have written the project. It is under IRB reviews and approval, and we think very soon we may be able to execute that work. So yeah, as I work in the hospital in this space, seeing a lot of these patients on ward, sometimes sitting in a clinic, to see them as outpatient, change their drugs, listen to their complication. I feel like it's not enough to wait for them in the hospital as the disease continues to bleed down in the community, because if we only just sit in the hospital, then it's like we are waiting for more and more to come, yet we know where the problem is, and probably we could tackle it from down there. Thank you.
Yeah, Dr. Kanyike, I think you're saying such powerful things, right? So you're talking about, and the producer's going to throw me out, because if I could, I want you to stand up and start clapping, because the work you're doing is exactly what's needed in the healthcare system, but also just taking down a couple of notes. I mean, you talked about blowing the NCD trumpet. I think that's so powerful. That's a really great quote. The second one is blood pressure is through the roof. I'll take that as a key takeaway today. And the third one is also the rise of cervical cancer and that transition between infectious diseases and non-communicable diseases, and that's across the African continent. So to those listening in, and to you as well, there's so many questions we have to ask you, I'm sure, between Joab and myself. But if you're comfortable sharing, of course, and if you don't want to, that's completely fine. But I've been itching to ask you, what made you, one, want to be a medical professional, and two, why the focus on NCDs? I mean, the scope of health is so broad. So really interested in your passion and why it's centered on non-communicable diseases specifically.
Yeah, thank you so much. So I think in the first place, why I've taken so much interest in organizations that are dealing with NCDs, and that I'm here today with NCDChild, is because of that passion that I have for NCDs. Why I wanted to become a medical doctor, as every other kid, as you are growing up, there is something that your parent puts into you. They do a lot in shaping the person you'd like to become, and probably you are most likely to train towards that, unless a bit of other social pressures come in and drain you away. But I think my parents did a lot in shaping my passion of becoming a doctor, because it is something that was always reiterated on dinner, in conversations, like, you a doctor. We are, paying for your school fees, but we want you to become a doctor. And I also had some uncles around me that were already healthcare professionals. One of them was a medical radiologist. So they kept giving me a lot of that inspiration, and I really wanted to be like them. So I really trended and worked towards that, and I also picked the passion as a person. So I'm in a place that I dreamt to be, and I worked towards being, because of the people that were around me, and what they really pushed and fed into me. And now, as you get into the medical school, there are a lot of other passions that drive you. Most of us have really been inspired by people like Ben Carson. So when we entered medical school, we actually wanted to be surgeons. You know, I want to be a surgeon, I want to be a neurosurgeon. But as you go through the medical school and start seeing these patients and other social factors around you, you finally get into the realistic docket that you want to be. And personally, me as a person, as I was going through medical school, at a certain point, my father developed these non-communicable diseases. Just all of a sudden, one day we at home just having lunch, he stands up to go to the bedroom and boom, just falls at the door of the bedroom. And we are like, what has happened? We are all over the place. Taking him to the hospital, that's when we get to know that he has hypertension. It's when we get to know that actually he has very high blood sugars and he has suffered from a stroke. It was really so abrupt, something very unexpected. And I was like, how could this come? It didn't bring any sign at all at the past. And, may his soul rest in peace, just rested last year. But, he has been battling through this. We have been spending a lot of money, trying to give him a life. And, these diseases are very expensive. They are very expensive given the fact that down here, we do most of the time out of pocket health expenditure. And sometimes it can really be very cumbersome. So there are a lot of things that come with these diseases, and that partly drove my desire to be able to help other people that are out there not to go through what I saw my parent go through, but also a lot of other relatives around. Most of them, we have really left them down, deep down in the ground, just because of these non-communicable diseases. So as a person, I actually hold the sentiment that these diseases are affecting almost each and every family, either directly or indirectly. You have someone in the family that is hypertensive, that is diabetic, that is suffering a stroke, or actually indirectly that person that is suffering from a stroke should have been helping someone earn a living, should have been paying school fees for someone, but they're incapacitated. They are down on their bed. They cannot maximize their potential because of a complication or a sequelae of this disease. And that's why I actually love using that quote of blowing the trumpet, because I feel like when HIV was ravaging the country in the 80s, everyone's mouth was on HIV. So the HIV trumpet has been blown, and those are the strides that we have been able to achieve. And I feel like we should do the same for these NCDs because they are really affecting each and every family.
Well, I really agree with you on the points that you've raised. And sorry about your dad. I feel that the fact that you have experienced NCDs as a caregiver and also as a doctor kind of puts you at a unique position, because you've seen both sides of the NCD, like of NCDs and how they affect people, how they affect families. It's really important. And then also the fact that you're so passionate about it and you have the ability to do something about it, and you are doing something about it. It's something that is so inspiring on my end. So as a healthcare professional and a caregiver as well, could you share more about the stigma and discrimination you've seen, maybe with your dad or as patients come to you? What have you seen out there? And you've actually mentioned that NCDs also have young people. They're not for old people, So could you please share more about that?
Thank you so much. That is really an interesting perspective, talking about stigma. And I can say that stigma resulting from diseases has been outrightly blown out in the case of infectious diseases, especially HIV, TB, etc., because of their contagious nature, the route of spread that has a moral connotation, which is, which morals are much valued in African society. and speaks to uprightness of oneself. However, like I told you, we see a shift in the trends of these diseases cropping up, and as they crop up, they carry around various other evils, and stigma is one of them that should be of much concern, because oftentimes it is an ignored, invisible complication of disease, which as doctors and clinicians, we don't look out so much. We don't really look out for it so much, as we concentrate much on the clinically manifesting attributes of the disease and try to rectify those. But when you look at stigma among the youth and even the elderly, as far as the NCDs are concerned here, I can say from a personal observation, I'm a researcher, and most times I like to speak from the fact, but stigma around NCD is something that has not really been so much done. But from a personal observation, interacting with these clients and patients, I feel like the stigma with NCDs is still more embedded within self. These people struggle with a lot of what I can say is internalized stigma. The negative feelings about themselves, knowing that their bodies can't go an extra mile, like maybe other kids or siblings. Taking an instance of, I've had quite some patients where, you have this young person battling with type 1 diabetes mellitus that happened out of the blue, is the only sibling at home with diabetes mellitus, and is really going through all these complications, having to take insulin injections, and you are the only one injecting yourself with insulin at home, and all the others are fine. And it creates a kind of a struggling picture within themselves. And when it comes to cancer, going through these cumbersome episodes of treatment, the chemotherapy, the radiotherapy, that is even ad-and in the first place, because the services are really inadequate here in Africa, and it's hard to get, proper treatment. It doesn't leave them the same. And I like to talk more about these cancers. When you look at cervical cancer, it really carries a lot of stigma around it, in form of social exclusion, due to the bad odor that may come out with a lot of these discharges that the ladies come, they have to clean up themselves every time, they have to change the pads because the flow of the discharge and the blood sometimes is too much. And, I've had to manage some women. There's a time when I was still in Mbale, that is in eastern Uganda, actually towards Kenya, Joab, towards Busia, where you stay. Some of these women, you could refuse to go back home. And they say, let me die from here. I'm not going back home, and I'm not going anywhere else. In Uganda, we have one cancer treatment unit, that is the Uganda Cancer Institute, that is in Kampala. So we had to refer most of these mothers to Kampala, but they are like, I'm not going to Kampala. And then we are like, maybe, okay, can you go home? Maybe we do palliation from home, give you the best of what you need before, you can breathe your last. But they're like, I'm not going back. I'm remaining here. You either do what you can do for me, or you leave me, just be on the hospital bed. After all, it's, a government hospital. I'm entitled to being on this bed. But when you sit down to discuss more with them, where they are going back at home, they are not having the best of the time there, because they feel like they are a burden to the people. And actually at home, probably they have been given a separate, secluded room, and they feel like they are on a death sentence. And that's a stigma, and that discrimination around them even makes the sentence shorter. So, these are areas that have not been given a research priority, but it would be amusing and surprising to find that the magnitude of the problem is way much bigger than it likely appears. And it would really require in-depth, research, exploration, but from an observatory eye, external stigma, like, people stigmatizing the people with NCDs, or like you have diabetes, I think I should not relate with you, is not so much yet into the picture, because it doesn't have a moral attachment. The way you get diabetes and all that is not linked to any immorality, or is not linked to any bad omen, I can say. But the society even yet doesn't understand very well how does a person get kidney disease, how do they come to get hypertension and all that. So the people outside don't have so much a negative aspect or all that to the people, but these people that are living with the disease within themselves, they have, this feeling, this downward expression of themselves. And, yeah, that's really what I think. And those are the sentiments I care about stigma as far as, these non-communicable diseases are concerned. Thank you.
Yeah, Dr. Kanyike, I think you've sort of unpacked so much, and there's a lot to talk about. And you talked about how even when patients go home in their own homes, they face stigma and discrimination, how they feel like a burden, and all of that really probably resonates with those listening in. Who deal with very different issues. I wanted to jump back a little bit earlier. You talked about we've made significant strides in the HIV community, and I wanted to say that yes, we have. We have lots of funding, we have lots of programs. We even have a stigma and discrimination survey that UNAIDS runs on a periodic basis, I believe. But at that very community and patient level, I remember when I started working in HIV about 5 years ago, someone had said to me, don't share teaspoons with with people in your office, or don't share a toilet with people in your office. And so, I think even among healthcare professionals, we also have these misconceptions, even among the broader community. And I think it also talks to the thing of, even though you have so much of investment, so much of focus and prioritization, at that very level, people and patients continue to face stigma and discrimination. And if it's okay here, we're going to do something slightly non-traditional. I know Joab is the incredible co-host, but Joab, also drawing on you as a patient, if you're happy to share again, of course, I'm always cognizant of that. What are some of the experiences you've had with stigma and discrimination?
Yeah, well, Shakira, as you said, and even as Dr. Andrew had said, stigma and discrimination is something very real and still ongoing, especially in like the NCD space. For myself, I experienced a lot of what I would call external stigma, where there were people who thought just because I'm on dialysis that I'm destined to die. Like I have no chance of survival. And that mentality, despite it having some, I guess a lot of people who end up with kidney disease do end up dying, but there's the hope of, trying to get the treatment that you need and being able to fight through it like I have. And so that in itself impacts you as a patient. So you talked about internal and external stigma. I feel externally, it starts externally and then we internalize it as patients, because that's all you're getting. When you go somewhere because of your condition, or you apply for a job and they realize, oh, this guy has chronic kidney disease or is on dialysis. Because of that, you miss those opportunities. So there's that kind of stigma and those kind of mentalities that eventually that's all you're seeing. Like imagine all you're seeing is people telling you, hey, that's the end of your life, or you don't really have much time left. So it starts to kind of finalize what you need to do. It'll impact you so much that internally you start to now think like that. You start to say, okay, yeah, let me die. As Andrew said, let me die here, because if I go home, I know that what I'm going to see. I know maybe my family or some of my friends might be like, oh, you're still here, that kind of mentality. So that's what I would say in regards to stigma and discrimination, is that it's sometimes very subtle. It comes in ways that you wouldn't expect it. It'll come from people you don't expect, and it could be as close as family. And they've seen you go through it and they've seen you fight. And they're the ones who are telling you, hey, how are you still here? So it's a very important issue, and like the HIV movement, I feel we need to adopt the energy, like Andrew said. We need to blow our trumpet and get out there and talk about it and say, hey, you know, if the HIV movement was able to get all these strides in the time they have, why can't we put that energy into NCDs and diabetes, hypertension, you know, kidney disease, so that people out there know that these exist, and there are ways to take care of yourself and live your life to the fullest as well. So that's what I would say, Shakira, in terms of stigma and discrimination that I've seen as a patient or as a person living with chronic kidney disease. It can be very subtle, it can be very unexpected, and it's something that we live with the rest of our lives as well.
And, you know, I think it comes down, Joab and Dr. Kanyike, it comes down to the humanity and the empathy and the ability to feel and connect and understand with the patient. And sometimes I go into healthcare professionals' offices and I don't feel that. But when I do feel that, it's vastly different. And so, Dr. Kanyike, you spoke so much about you know, the barriers to care, the out-of-pocket payment, what it costs to get healthcare. And you're working between the public sector and the private sector. And I'm just wondering, you know, what are some of the barriers that people living with NCDs continue to face? Is it drugs, stockouts, etc.? One. Two, what's the sort of patient load that you have in these facilities? Do you even have time to sit down with patients living with NCDs? Do you have time in your consultation to go through some of these issues?
Yeah, thank you so much. I would say when it comes to the barriers to, you know, to care, they would be quite hinged around money. And when you look at the public sector, usually it is free medical care. You are not supposed to pay, but the hospitals are not well equipped, especially to manage non-communicable diseases. You know, these are batteries of expensive tests that you're supposed to do. Joab, you can even attest to dialysis in Uganda. Just one session of dialysis is about 1M every time you have to do it. And you can imagine if you have 3 sessions of dialysis in a week, you have to have 3M. And an average Ugandan earns around about 15,000 or even below. Very many of us are below the poverty line. We can't really manage that. So people that are in the public hospitals, where, you know, in quotes, healthcare is free, but the things are not in place, and actually you have to outsource. That means you have to get out of your pocket. They are not able to get these tests. So you see a patient on Monday, you think, you know, they are diabetic, you think they have had, kidney disease as a complication of the diabetes and the hypertension. You want to investigate them, you want to do renal function tests, you want them to have an ultrasound scan, you want them to have a CT scan, and you know they cannot get this. Down the road, Tuesday, Wednesday, Thursday, Friday, you spend a week with them on ward waiting for the tests, and they can't get them. You get the tests, and later on you prescribe the medication. Maybe they can get some in the hospital and they have to buy others, and they are not able to buy them. The management becomes complicated both for the patient and the doctor. As a doctor, you get frustrated because you cannot be able to manage your patient properly. You cannot be able to get the results that you want to see because of the constraints on the end of the patient. But also the patient is constrained because they want to get well, but they cannot because they are financially constrained. And the story becomes a little different in the private setting, you know, because people can a bit of access the tests and the drugs. They are available, but the price, the costs in as well in the end become cumbersome to them. They can go only a particular mile, and they can no longer go any further. You know, they kind of start to give up because, you know, maybe they have tried and they have managed to get some money for the first 3 sessions of dialysis. but they can no longer go on. They have to make a family conference, they have to make a fundraiser. And we have a lot of fundraisers that go around on our social media and what so and so needs dialysis, goes into these sessions per day, per week we need this, per month we need this, and doctors think you may need to be on dialysis for 2 months, and they come up with a total figure. They make car washes, social media drives. A lot of those happen down here. There are very many because people are struggling and they cannot manage. We recently lost one of our colleagues. As back as we are going through the medical school, he got some problems and she needed dialysis. And we were supposed to collect fundraise money as the class every other time. So sad to see that our colleagues manages to get the dialysis and these other expensive tests that they are supposed to get each and every time. So really, the out of the pocket expenditure is cumbersome. And the patient load, as you are seeing these patients, sometimes yes, there are many, because they are coming for the service. They want to see the doctor and go back to work. You are taking money, they have to make the money. They won't have all the time in the hospital. So sometimes you have the time really to talk to some. Sometimes the day is not good and you have a lot of them and you only concentrate on the clinical aspect. You have any complication, please do these tests. I think you need to take your drugs a little more properly. And yes, the next patient coming. And that's all. Sometimes you get that one who really is down and wants to talk about this. And you have to squeeze a little more time for them to talk about it, but you may not have all that time explore all the social aspects around them. So yeah, these diseases have a lot of catastrophe with expenditure, and that is a very big issue with these patients.
Yeah, the financial side of it is, the financial burden is a lot, and thanks for raising that, Dr. Andrew. It's true, it's quite something most patients can't afford, especially here in Africa, and it's quite an issue that we need to really look into and talk about. So, cognizant of the time, could you, in 1 minute, tell us your final message in regards to stigma and discrimination and NCDs? What would you say? If we could just say one powerful line, what would it be?
Thank you. Like I said before, I would reiterate again and every other time that we need to wake up and blow the trumpet of the non-communicable diseases. They are living right in our backyard. They are in our blind side, and we don't need to wake up, in backside when things are blown out of proportion, when we still have a chance to tackle them when they are still within the manageable realm. So yeah, we need to wake up and talk to NCDs because they are with us, they're in our community, and they are claiming a lot of our lives. Thank you.
So there we have it, Dr. Andrew Kanyike, Joab, Wako. It's been such a enlightening couple of minutes this morning, and whoever's listening in as well. I think the issues that you've unpacked, Dr. Kanyike, in terms of, again, the financial cost of getting care, but also operating within the public system, private system, the higher levels, the community levels. Are you able to actually reach communities? The type of work that you're doing on awareness raising, your own experiences as Joab said, a caregiver, but also someone who's now a healthcare professional and really keen about these issues. And that's exactly what this podcast series is for, is, as we said, it's not just for the HIV community, it's not just for the NCD community, it really is for patients all across the world, and the healthcare sector as well, because when we think about, at again, the human level, are we serving humanity? Are we serving learning patience. I think that's so critical. So you leave us with that. You leave us with a really powerful quote of blow the trumpet on NCDs, which we hope will be taken up in some campaign or the other. We thank you for joining us, sharing the Ugandan experience, the African experience to Joab as well. Again, to those listening in, please do tune in to future episodes. We have 5 to 7 episodes in the series. The campaign is known as Stand Up, Speak Out, led proudly by NCDChild young leaders, Joab, Apuva, Belindi, and myself. Catch you soon.